Hi everybody, hope all are safe and healthy. I welcome you all to the second last pharmacology research session. This week the problem that's been discussed for you is a patient with acute chest pain, and then the patient was diagnosed to have myocardial infarction. Hence this session has been scheduled where primarily we are going to see the drug class called thrombolytics, otherwise called fibrinolytics. I want to clarify one point. Although these are the immediate class of drugs that will be essential for the patient, there are quite a few of other drugs which are used for treating a patient with acute myocardial infarction, such as aspirin, clopidogrel, morphine, beta blockers, statins, etc. I am not going to discuss about drugs used in managing acute myocardial infarction now, because there is a clinical session scheduled, and I am sure that the concerned clinician will be talking about these. And in prescription writing we have a problem related to acute MI. So there we will discuss briefly about the different drugs used in that condition. Otherwise, in this resource session, it is going to be entirely focused on thrombolytics as a class of drugs. Whenever there is a damage to the blood vessel, when there is a discontinuity of the endothelium, the circulating platelets will be exposed to the subendothelial collagen tissue, and the platelets will be activated and they aggregate. Simultaneously, there is also activation of the coagulation cascade that finally results in the formation of fibrin, which form a meshwork like this, right? Like this, over which the platelets will aggregate, and this form a big mass called thrombus. In addition, the molecule called fibrinogen, which is again an inactive clotting factor, binds the platelets. It is the molecule which is essential for platelet aggregation. Because of this thrombus, which forms in the coronary artery, it can form in any artery or vein, but relating it to the present problem where the thrombi is formed on the coronary artery, it blocks and it results in myocardial infarction. So the cells which are supplied by the concerned blood vessel, which is blocked by the thrombi, will die. So in such patients, our therapeutic objective will be to break the thrombi, which can result in reperfusion of the cells. If you recollect the coagulation cascade, which we have seen earlier in the presentation related to anticoagulants, fibrin formation from its precursor fibrinogen is the final step. And this is mediated by this conversion of fibrinogen to fibrin is mediated by thrombin. So thrombin cleaves the components, inactive components from fibrinogen, which result in the formation of active fibrin. And this fibrin forms the meshwork over which the platelets will start aggregating, and this results in the thrombi. As our therapeutic objective is to break the thrombi, it will be possible if and only if you break the fibrin polymers which have been formed. So if you can break this fibrin polymers into small inactive products, small products, then there won't be any meshwork over which the platelets will stand, and so it will be washed away by the circulating blood, and this can effectively lyse or break the thrombi. Physiologically, for doing this, we have a substance in the blood called plasmin. So plasmin cleaves the fibrin meshwork into small molecules which are referred to as FDPs, fibrin degradation products. And this fibrin degradation products, apart from not having a meshwork as like fibrin, it also has certain active properties, such as FDPs prevent aggregation of platelets themselves. They also inhibit formation of the clotting factor 2, thrombin, and they also inhibit polymerization of fibrins. So all these are good properties related to thrombus. The only catch here is this plasmin, which is going to produce fibrin degradation product from fibrin, has to be synthesized from an inactive molecule called plasminogen. Only then you can have formation of FDPs, and subsequently you can lyse the thrombi. Our class of drugs, the so-called thrombolytics, facilitates this conversion of plasminogen to plasmin. So the mechanism of action of all the thrombolytic drugs is to stimulate or activate conversion of plasminogen to plasmin. and this plasmin will degrade the fibrin to FDP, fibrin degradation products, and thereby you achieve thrombolysis. Please keep this in mind, the mechanism by which thrombolytics act. You need to remember the production of plasmin from its precursor plasminogen. There are nearly half a dozen of thrombolytics used. Cheap, very well used, has been available for the last several decades. Prototype for this class of drugs is streptokinase. We also have urokinase, anistreptase, altiplase, tenecteplase, and retiplase. So these are the 6 thrombolytic drugs that are in use, and you can see all of these end with suffix ase because they are kind of enzymes which convert plasminogen to plasmin. Streptokinase is obtained from hemolytic streptococci, beta hemolytic streptococci. Urokinase is obtained from human kidney cells. And these 3 agents are obtained by recombinant DNA technology. So you need to keep in mind about the origin of streptokinase because it has an important clinical implication, as well as these 3, altiplase, tenecteplase, which have origin which are derived by recombinant DNA technology. So these 2 are clinically important. Another feature that distinguishes these drugs, which is clinically important from safety point of view, is their specificity to what is called as tissue bound plasminogen or fibrin bound plasminogen. As we are discussing, this class of drugs are going to activate the conversion of plasminogen to plasmin, and thereby they are going to lyse the thrombi. There are 2 types of plasminogen. The first is the type which is bound to the fibrin which is formed at the site of injury. This is also called as tissue bound or fibrin bound. And the second type of plasminogen is circulating plasminogen, which is the plasminogen inactive molecule which is circulating in the blood. It is not bound, it is not restricted to the site where the injury has occurred. There are certain thrombolytics which are specific to tissue bound plasminogen, which means if you administer the specific thrombolytics, then they cause conversion of plasminogen to plasmin only at the site where the thrombi is located. But we have another type called non-specific activate thrombolytics, which activate both the tissue-bound plasminogen as well as circulating plasminogen. So because of this non-specificity and because these drugs activate the circulating plasminogen, so in other sites where the thrombi is not formed, there also you will have conversion of this plasminogen to plasmin, and this plasmin degrades factor 1, 5 and 8. So thereby, if you reduce these clotting factors, then the patient has increased risk of bleeding. So this is the problem or disadvantage with those thrombolytics which are non-specific. So they activate both tissue bound, which is going to give them the thrombolytic activity, as well as they activate circulating plasminogen, which is going to increase their risk of bleeding. So this is how we classify the thrombolytics. This is important for you to keep in mind. So we have 3 thrombolytics which are specific only to that plasminogen which are bound to fibrin at the site of thrombi. So we have mnemonic RAT, retiplase, altiplase, tenecteplase. These are obtained by recombinant DNA technology. So these are specific. They are very good. They have reduced risk of bleeding because they are specific. And we have 3 others which are non-specific, which is USA, which is toxic, right, which has increased risk of causing harms, not USA, but urokinase, streptokinase, anistreptase. So they have increased risk of bleeding because of their non-specific activation or conversion of plasminogen to plasmin. So in general, if you have a question like which thrombolytic is the drug of choice, choose one from fibrin specific or rDNA because their safety concern is much less compared to the non-specific ones. And amongst this RAT, the tenecteplase T is the longest acting. Okay. So this is important. Please keep this fact in mind. Another clinically important point is for streptokinase because this is the cheapest of all the thrombolytics. It's used worldwide. Many of the developing nations, they use streptokinase, and even in developed countries, for patients who are unaffordable, who do not have health insurance, for whom the government cannot provide much support, streptokinase is often administered as the thrombolytic. This streptokinase is obtained from beta hemolytic Streptococcus pyogenes. In fact, it is one of the naturally occurring enzyme that you see on the cell wall of Streptococcus pyogenes. Why is this important? Because you have it in a microorganism, when you administer it to patients, they may react to it and they may produce antibodies against streptokinase, and they may often have fever and chills during infusion. These antibody, which is produced when streptokinase is administered for the first time, it persists for a minimum period of 6 months. And some studies have even shown that it persists in some patients till 2 years. So what is the clinical implication? If you have a patient who has received streptokinase within last 6 months for thrombolytic purpose, you should not give it again. If the patient has another attack of infarction or arterial thromboembolism or ischemic stroke within 6 months of prior streptokinase administration, they should not be administered. If you are going to administer it within 6 months, the antibody will already be there and that will neutralize streptokinase. So this is one important point. Second, we have seen, I think in the third problem in this unit, an adolescent with rheumatic fever. And that's because again of the same organism, beta hemolytic streptococci, pyogenes. So when you have a patient who is a known case of rheumatic heart disease, rheumatic fever, who has been exposed to streptococci, again it's quite possible that the antibody will be there in his circulation. So for such individuals, again streptokinase will not be highly effective. In fact, streptokinase is not a thrombolytic agent of choice in areas where group A hemolytic streptococci is endemic. So it is never ever a thrombolytic of choice. In countries like Australia, New Zealand, particularly in the northern part, which are endemic to such streptococcal infection. So we need to consider other thrombolytics. So these are some of the clinical implications because of origin of streptokinase from a microorganism. In general, thrombolytics are indicated for major arterial and venous thromboembolic disorders, such as in case of arterial, as in the present case, myocardial infarction, particularly when there is ST elevated myocardial infarction. Sometimes it's possible that one of the arteries supplying the brain, one or the more region of brain, could be blocked. That results in ischemic stroke, or subclavian artery could be blocked in patients who have high risk factors. Amongst venous thrombotic disorders, it's DVT. If you don't adequately treat, it might result in pulmonary embolism. So all these are the important indications for preferring to administer one of the thrombolytics. As I reiterated before, for any of these, If you have a question, the best thrombolytic, choose the one from recombinant DNA technology. Choose the one from rat, retiplase, altiplase, or tenecteplase. As this unit is focusing on cardiovascular problems, I'm just taking only the STEMI indication for thrombolytics. If you have a patient with ST elevated myocardial infarction with symptom onset within last 12 to 24 hours, definitely reperfusion therapy is the best. And how do we achieve this reperfusion? One of the two ways. You could use a surgical intervention called percutaneous coronary intervention, which is shown in this figure, or second is pharmacological, which by use of thrombolytics. Certainly, this is the best. Percutaneous coronary intervention is the best, which is carried out by inserting a stent through femoral artery, and it will be taken to the site where you have the thrombus in the coronary artery, and it will be dilated, and then it reperfuses the distal tissue. This is the best, there is no doubt about it. But there are hardly or not many hospital setups where PCI is done round the clock. Ideally, from the onset of STEMI, PCI should be done within 90 minutes for the best results. Many a times it is not possible, and the health center where the patient goes first may not have that facility. So from there, if the patient is referred to another center where PCI is available, at least within 2 hours, if it is done, it will give you a reasonable benefit. Almost you can avoid the complications, you can have as good as a normal or a close to normal myocardial tissue. However, when such facility is not available due to one or the other reason, or when you expect a delay of more than 2 hours for PCI to be carried out, then thrombolytics will have a major role. Again, within last 12 hours, if you administer thrombolytics, you will get the best therapeutic outcome. If the duration or if the time at which thrombolytic is administered from the onset of STEMI is about 3 hours, then the efficacy of the thrombolytic will not be to its optimum. Nevertheless, within 12 hours of onset, or even some do say within 24 hours of onset, you could consider giving thrombolytics, although the benefits are certainly not well established. And guidelines do recommend that from the moment the patient steps onto the hospital, when you make a diagnosis of STEMI and you are certain that PCI is not available at all or not available within 2 hours, certainly within 30 minutes, you need to administer thrombolytics. So please keep these timelines in mind, right? Best is within 30 minutes from the moment he steps onto the hospital. In general, best is PCI, and that too within 120 minutes is good. If you expect a delay of 120 minutes or if PCI is not possible, then thrombolytics are administered. In such case, within 30 minutes of having reached hospital, if you give thrombolytics is best, which also include within 3 hours of onset of chest pain. Beyond 12 to 24 hours from the onset of chest pain, the benefits of thrombolytic is questionable. There are some precautions that you may have to take before, during, and following the administration of thrombolytics. Before you administer thrombolytics, you need to ensure that the patient doesn't have any of the contraindications. This is a very busy slide. So the contraindications are absolute and relative. Forget about relative at your level, but at least it's essential that you keep in mind absolute contraindications. And this is the mnemonic that you can use to remember absolute contraindications for thrombolytics, which are: if the patient has stroke, a prior stroke, not the present stroke, it's a prior stroke. Within last 3 months, absolutely patient should not be given thrombolytic. If the patient has intracranial hemorrhage before, certainly no. Similarly, a significant trauma to the face or the head region in the last quarter, 3 months, certainly no. O for pregnancy. This is actually, pregnancy is P, but remember the pregnant women will have a tummy, right, which looks like a O. So that's why just remember that one, pregnancy. Any malignant neoplasm, cancer in the brain. Uncontrolled hypertension should not be given. Patient will be at high risk of bleeding. Any active bleeding at the moment, or a patient has a bleeding disorder, then again certainly thrombolytics have to be not administered. And we have nothing, forget about this. And dissection of aorta, if there is an aortic dissection suspected, again don't give. And in case of streptokinase, if the patient has received within the last 6 months, or is a known case of rheumatic fever, rheumatic heart disease, had a recent streptococcal infection, then better to avoid streptokinase. So just before going to administer thrombolytics, assess for the presence of any of these contraindications and rule all these out. So that's what you need to do before. And while administering thrombolytics, you need to continuously monitor. Thrombolytics most often, except for a few, are administered as infusion. For example, if you take streptokinase, it's administered as infusion for 30 minutes. We have retiplase which are administered as bolus, just a push is enough. But during the administration of these thrombolytics, you need to see whether the patient has bleeding. If the patient has any bleeding episode, then immediately you need to stop the infusion and may consider administration of one of antifibrinolytics such as epsilon aminocaproic acid or aminocaproic acid, tranexamic acid, aprotinin. So these antifibrinolytics do exactly the opposite compared to fibrinolytics. Fibrinolytics facilitate conversion of plasminogen to plasmin. Antifibrinolytics inhibit this conversion. So they are the effective antidotes to be considered for bleeding due to any of fibrinolytics. And while administering fibrinolytics, you need to continuously monitor for the cardiac activity, because when the thrombi is lysed, there is going to be reperfusion of the distal tissues. And when the areas are suddenly reperfused, it's possible to have reperfusion arrhythmias, which could be fatal in some cases. So it's always important to continuously monitor the cardiac activity during thrombolytic administration. Once it's over, the thrombolytic is over, at least observe him for 6 hours, keeping him bed rest. As usual, observe for any signs of hemorrhage. And it's also possible that some patients could go for a rethrombosis, reocclusion of the coronary artery by a fresh thrombi. So you need to continuously monitor heart cardiac activity as well as any onset of chest pain symptoms like that. So with this, we complete this short session on thrombolytic. As I reiterated, management of acute myocardial infarction is not listed as a resource session for me, and I'm sure the clinician will cover on this, and we'll also see it in the prescription writing. So these are the answers to the previous MCQs, and there was one question from a student who was asking, should we use beta blockers for stable angina only or unstable? Because at the last I have provided beta blockers for unstable too. Beta blockers, their common indication is chronic stable angina. But they are also one of the drugs to be used in unstable, because such patients can have myocardial infarction, that such patients can have arrhythmias, and we have seen to prevent cardiac remodeling, beta blockers are one of the important drugs. So they are also used in unstable angina. If the patients have concomitant asthma or a peripheral vascular disease, beta blockers are not preferred and calcium channel blockers can take over their place. But if a patient has variant angina or Prince-Metal angina, calcium channel blockers are the preferred. And nitrates are used in all the 3 types of angina. Just a clarification on their specific indications with regard to stable, unstable, or Prince-Metal. And I have a couple of questions here for this resource session. Please go through it. And if you have any question, please revert to me. Thank you and stay safe.